Hello, hello everyone. Hello, hello. I see people trickling in. That's nice. Welcome to the TBPPM webinar on patient journey and patient pathway analysis. Really happy to see you all. Thank you for joining. I'm going to just do a few background logistics to make sure that we have our different speakers. Thanks everyone for joining. We are also live streaming on YouTube, and we are turning that on right now. If I am doing the right thing, I'm sorry. Hello, everyone. Hi, Lavanya, good to see you. Hello. I'm glad to see you. Hello, everyone. Thanks so much for joining. Good morning, good afternoon, good evening to everyone. So happy to have you on this TBPPM webinar. Today, we're going to be talking about TB journeys and TB pathways for people that are affected by TB. We all know they have an incredible journey to go through, and often it starts by seeking care, and we like to understand these pathways better. So today, we're listening to several excellent speakers who will be explaining to us some of the background analysis, the methodologies, and some of the data that they have found in their patient pathway analysis. So this is a 75-minute webinar. We are live streaming on YouTube as well. You can use the Q&A for any questions. That makes it easier for our wonderful moderator to answer your questions. And also our panelists can be in that way easier respond to your specific questions. You can use the chat as well. Please turn on subtitles for your own use. We will be sharing everything, the recording, the presentations, and a news post with a report around next week, and we will be live tweeting as well for those of you who can't follow. Please join the TBPPM Learning Network so that you get updates on anything that comes out this webinar or any future webinars. And now I would really like to introduce my colleague and friend, Charity Omenka, who is an associate professor at Waterloo University. She has been doing a lot of research on private providers, on public providers, the pathway of patients, and many other topics that are linked to tuberculosis. And I'm really keen that she is helping us moderate today's webinar. Charity, can I hand over to you and let you introduce our panelists? And looking forward to hearing. Thank you so much.
Yeah, thank you, Petra. Really wonderful to be here. It's always exciting for me when I participate in any of the TBPPM webinars. So my name is Charity. As Petra said, I'm an assistant professor with the University of Waterloo. Today I'm joined by, three wonderful panelists that I will introduce shortly to discuss patient pathways or patient health seeking experiences and journeys. As we know in TB, every year like 3 to 4 million cases are missed. And so finding them is one of the end TB goals and is very key to ending TB in our lifetime, right? So one way that can help us all to sort of understand the challenges that patients go through when they're seeking care for TB is the patient health seeking analysis through the patient pathways or through the patient journey. So right now I'll just introduce my co-panelists and then we can get started. First, we're joined by Christoph Whipple. He's an Austrian physician and computational epidemiologist. He's currently working as a postdoctoral fellow with the Fahart Lab at Harvard Medical School's Department of Biomedical Informatics. His research focuses on understanding the transmission dynamics and drug-resistant emergence of tuberculosis in South Africa. Christoph has also worked in the COVID-19 emergency team at the World Health Organization in Copenhagen, where he analyzed epidemiological impact of public health measures on the SARS-CoV-2 virus. His projects in the past also have included studying TB patient pathways in Lima, Peru, and in India, and he's here to discuss some of that work with us. He holds a master's degree in global health from Harvard University and a medical degree from the Medical University of Vienna. We're also joined by, so welcome, Christoph. And so we're also joined by Lavanya Uria. She's a research analyst with Broad Street HEOR and has been working in health economics and outcomes research since 2023. Lavanya's work has covered several disease areas, including tuberculosis and some rare diseases. She has contributed to systematic and targeted literature reviews, so she's an expert on literature reviews. She has also collaborated on cross-sectional research studies and qualitative research studies. Lavanya completed her graduate studies at McGill University and master's in epidemiology, and holds a bachelor's degree in economics from McGill, where she specialized in developmental economics and statistics. She's co-authored several papers in very reputable journals. We are also joined, welcome Lavanya, we're also joined by Bonnie. Bonnie is with the Universitas Padjadjaran in Indonesia. She's a medical doctor with 19 years of working experience. She has a master's degree in clinical epidemiology from Erasmus University. Her professional career ranges from clinician, public health practitioner, researcher, and lecturer. Her work has introduced her or with many collaborative partners such as the Ministry of Health, government and non-governmental institutions, also international companies. She has been involved in planning, organizing, budgeting, monitoring, and evaluating different programs. So welcome, Bonnie. So I'm really excited to discuss patient pathways and patient journeys with this wonderful panel. So to kick off, I will hand you over to Christoph. Christoph, over to you now. Feel free to share your slides.
Thank you so much. Thank you for this introduction. Let me just share my screen. One second.
Yeah. As he presents, feel free to drop your questions in the chat or raise your hand, and from time to time I would come back and find out what your questions are. All right.
Can you see my screen? Okay. All right, thank you so much for the introduction, Charity, and for the opportunity to talk about our research here. I'm very happy to be here, and I hope this will be informative for many of you. As you can see from the title, we conducted a patient pathway analysis in form of a mixed method study in Peru, in Lima. And this actually just got published last month. So for those of you interested in more detail, I will link the article at the end so you can read the full article. And without further ado, let's get started with some background. So as you all know, tuberculosis is the deadliest infectious disease that we're facing currently. And it is estimated that nearly 1/3 of all of the people infected with the disease never receive an accurate diagnosis and are consequently also not treated adequately. And we know that access to healthcare services plays a huge role in this, with limited access and lack of means to diagnose being important factors in many of those misdiagnoses. And from previous patient pathway analysis, we know that depending on the country and the size of the private sector, at least 20% and up to 90% of people with TB first seek care for their TB symptoms in the private sector. And despite this fact, many national TB programs engage very little actually with private healthcare providers. And very little is even known about the availability of diagnostic services within the sector, since regulatory agencies typically don't cover private facilities comprehensively. So there is often a lack of even basic information about this. And yet, especially in Asia, where the private sector is very large, there have been, in many countries in Asia, there have been examples where it could be shown that engaging the private sector led to direct increase in the TB case detection and also improve treatment outcomes. And various models for partnerships exist actually. But in Latin America, the literature on the role of the private sector is extremely scarce, and we know even less. And the few studies that have looked at this have shown that also here a sizable portion of patients with TB turn to the private sector, namely around 20 in those studies. There was 22 in Mexico, 35 in Nicaragua, and 41% in Peru. And a recent systematic review on public-private partnership models for TB also highlighted this knowledge gap, as it included 78 studies across the world, and only one of those was from a Latin American country. So our goal was therefore to gain a better understanding of the current and potential role of the private sector in TB diagnosis and management in a Latin American country. And how did we do this? We used a convergent mixed method study design, meaning we had a quantitative component that was the patient pathway analysis. And what that is basically a standardized way of evaluating the alignment between care-seeking behavior and TB services. And with this, we wanted to understand TB diagnostic and treatment capacity in health facilities where patients with TB first seek medical care. And the patient pathway analysis draws from multiple data sources. Number one being patient care-seeking behavior. And we got this data from a previous study from 2017 that looked at this across Lima. And then data on TB service availability, including smear microscopy, chest x-rays, and treatment. That was not available for the private sector. Therefore, we conducted surveys ourselves with private providers in North Lima in 2022. And then data on services in the public sector we obtained from the North Lima Regional Health Authority and from public websites of the employer-based public health insurance. And then lastly, we used WHO TB incidence and estimates to estimate the overall case detection, as well as data on notification and treatment outcomes for North Lima from the National TB Program. And then in the qualitative component of the study, and this is what really sets our PPA or patient pathway analysis apart from other such analysis, because it is the first one that supplements the PPA with qualitative data. And in this part, we really wanted to elaborate and clarify and explain the quantitative results. And we focused this part on exclusively on the private sector because the public sector TB services are, as I mentioned earlier, much better understood. So for this qualitative part, we recruited private healthcare providers from among those that we surveyed from the PPA for semi-structured in-depth interviews. And we purposefully sampled an equal number of providers who had stated in their surveys that they had diagnosed at least one patient with TB in the past year and those who had not. And since we only had a limited number of providers who had diagnosed TB, we further used snowball sampling as a technique to increase this sample by asking interviewees to refer us to other information-rich private health providers in North Lima. And in total, we ended up with 18 private provider interviews. And then we also recruited 5 additional key informants for the interviews who were knowledgeable about the policy situation and policies that affect TB services in the private sector, including from the Regional Health Authority, the Ministry of Health, and our partner organization, NGO, Socios en Salud. And for the content analysis, we used a conventional inductive approach where we transcribed, translated, and then coded the interviews, and then we generated descriptive categories through an iterative examination, and then identified the themes that we'll talk about in a minute. And then finally, we integrated the quantitative and the qualitative results by overlaying the qualitative insights onto the PPA indicators using a joint display. And this allowed us to understand how the private sector might serve as a facilitator, as well as a barrier to TB care at different points along the patient pathway. Just a little bit of more context. So we have We conducted this study, as mentioned, in North Lima, in the northernmost administrative region of the capital. And oops. It is comprised of comprises 9 districts and is characterized by high rates of poverty and poor housing conditions. Just the basics of the healthcare system in Peru. It is made up of 3 main players. 2 of them are in the public sector, with the largest component being the Ministry of Health, or MINSA, which provides government insurance to those who lack other forms of insurance. And then the second public component is called Salud, which is affiliated with the Ministry of Labor, and it serves those with employer-funded social insurance. And then lastly, the private sector, which services people who pay out of pocket or have private insurance. And now let's look at some of the results. So here you can see the 5 main steps of the patient pathway, into which we classified the qualitative results. And on top here, you can see how the 8 patient pathway analysis indicators map onto those steps. And let's go through them one by one, and I will highlight not all, but some of the most pertinent qualitative results that we found. Let's start with when the patient first comes to the health facility. So we found that we estimated that there were 496 functioning private facilities in North Lima, and 100 MINSA primary care centers, and 2 MINSA hospitals, as well as 9 Salud facilities. And 41% of people with TB first sought care in the private sector, and 31% at MINSA primary care centers, 26% at MINSA hospitals, and 2% at Salud. And these data are extrapolated from the study that I mentioned earlier from 2017. And then the qualitative results gave us some clues why so many patients may seek care in the private facilities, even though for most of them, they're out of pocket. So according to the private providers, even though the general population is aware that treatment for TB is provided for free in the public programs, people may not recognize their symptoms as indicative of TB, and therefore initially seek care in a private facility, which may be the facility that is closest to them or most conveniently accessible. And then if we look at the diagnostic process itself, so we looked at diagnostic coverage in terms of percentage of facilities in each category that provided smear microscopy and X-rays, as these are the standard methods used in Peru. Smear microscopy was offered in about half of the private facilities and all of the MINSAs and Salud facilities. X-rays were offered in only 17% of private facilities, and the MO, Ministry of Health, is primary care centers, and in all of the Ministry of Health hospitals, as well as the Salud facilities. So private providers believe that one of the strengths of the private sector was actually the ability to arrive at a faster diagnosis because of the availability of more advanced technologies. However, we found that access to such services seems to be dependent on the patient's financial means, and it was suggested by some that some may bypass basic tests to proceed immediately with more advanced and sometimes unnecessary tests. That was the notion that came up in the interviews. So what happens once a diagnosis is reached? Overall, we estimated that 77% of people with TB initially sought care at a facility with TB diagnostic capacity, and the lack of initial care-seeking location was driven by the people who initially went to a private facility, because all public facilities offered at least smear microscopy. And private providers overwhelmingly agree that their main role lies in the early detection and diagnosis of TB as opposed to the treatment. They saw that their strength was in the availability of resources, speed of diagnosis, and access to more modern technologies. Some providers proposed expanding the private sector's early detection potential. So that was also something that came up. Now, what about treatment? So none of the private providers offer treatment of TB for TB, whereas treatment was available in all of the MINSA facilities and 8 of the 9 Esolute facilities. And after referral to the public sector, the responsibility for treatment was often, that's something we found came up in interviews, kind of shifted to the patients themselves, as the referral was by many providers, private providers, seen as a handover to the public sector, and then it was the public sector's responsibility or the patient's responsibility to get there, and they expect that the patient will receive treatment there. However, there are no standardized systems for information sharing between the sectors. And some providers express the desire for better feedback from the public sector on referred patients. So let's look at what are some of the takeaways that we can conclude and conclusions. So number one, our study highlights the important role the private sector plays in the diagnosis of TB in North Lima. Private facilities greatly outnumber public facilities in this setting, and many people with TB use the private sector despite having to pay out of pocket. However, there is limited, as we saw, limited availability of diagnostic services in the private sector, which means that about 1/4 of the patients with TB seek care at locations without TB diagnostic services. And our results also show the potential benefits of closer collaboration between the sectors to improve TB detection. Providers in our study were very comfortable referring the patients to the public sector for treatment, and they did not make a call for treatment in the private sector. And that was mostly due to the stringent regulatory environment, which has the goal of preventing substandard TB treatment in the private sector, that could create favorable conditions for drug resistance. However, this appears to have created a financial disincentive for the private sector treatment in Peru. And then we found that the main barrier that hinders effective cooperation between the two sectors is the lack of communication and information sharing. And effective strategies to solve this could be, for example, formal public-private partnerships where the National TB Program provides technical support for private providers, and another one is establishing feedback mechanisms after referral from the private sector, as well as a standardized referral system. And in conclusion, we can say that the private sector plays a pivotal role as an entry point of care for a sizable portion of patients with TB, and putting the right systems in place and strengthening the linkages between the sectors could yield great results in terms of increasing the detection rates and making treatment more timely, and ultimately lowering the rates of transmission of TB. And I want to end with some acknowledgements to, first and foremost, my mentor, Courtney Yuan, who I think is in the audience, and also my secondary mentor, Hannah Gilbert, and the rest of the research team and co-authors, as well as the Master of Global Health Delivery Program and the David Rockefeller Center for Latin American Studies for their financial support. And thank you all for listening.
Thank you, Christoph, for your presentation. It was really very useful and very interesting to see how your analysis was able to highlight some of the bottlenecks in the system for patients, and also help to highlight where there would be a need to increase collaboration between the public and the private that was probably overlooked before then. And I hope that the results are being put to good use. So from Christoph's presentation, you can see how beneficial patient pathway analysis can be, in just understanding where are they having difficulty the most within the system. The methodology he has used is called the patient pathway analysis. And the methodology that our next speaker will be talking about, while we sometimes use it interchangeably, it's not the same methodology. That one is the patient journey analysis. And so while Christoph's methodology looks at the system part, and then very innovatively, the team also like went through, used qualitative methods to sort of highlight what are some of those, or the reasons behind some of the results they found with the analysis. This one, the patient journey analysis, starts with the patient and just ask them, like looking at the different steps in care, where did you find care? How did you, what were some of the barriers that you found? And I'm not going to speak too much about it because Lavanya is going to take us through some of the analysis that we did using a sample from Indonesia. So we did a large study, and we collected data from Nigeria, Indonesia, and India. And Lavanya is here to talk to us about some of our findings from Indonesia. Thank you, Lavanya. Over to you.
Thank you so much, Charity. So yeah, hi everyone. My name is Lavanya, and just give me a second to start my slides. All right, is everyone able to see the slides? Okay, perfect. So yeah, hi everyone. My name is Lavanya, and today I'm going to be sharing some of the steps that I use to analyze the data from the COVID study, as Charity mentioned, to write and publish a manuscript. So we'll quickly skim through a background section, the rationale behind the whole project, the objectives of our study. I'm going to talk a little bit about the description, about our data source, before going into the main topics of our presentation, the analysis and some recommendations for best practices. So this is a pyramid that I want us all to remember. First, we're going to start with the first question. What is feasible? How will we achieve our goal of proving a theory that we may have, answering the question that we think will have the most impact? And if you don't know what your question is or how you're going to answer the question that you already have, that is good news, because when you sit to find out these answers, you won't be biased towards one methodology or one predetermined answer or one theory that you're trying to prove, which is, I recommend, the best practice. So let's begin where most researchers begin, with a literature review. It is up to you if you want it to be extensive or targeted, and there's many ways to do this. In my manuscript, I used a targeted literature review to kind of just set the story and explain how I wanted to analyze my data. So setting that stage, before COVID was declared a pandemic, TB was the world's leading infectious killer. In 2021, there were 10.6 million incident cases and 1.6 million TB-related deaths. The biggest barriers in TB control remains locating the missing people with TB, individuals who remain undiagnosed or are diagnosed but not notified to the National TB Program. The COVID pandemic widened this gap, and the world saw a massive drop in TB notifications during 2020 and 2021 as compared to previous years. Studying health-seeking behaviors during the pandemic in the private sector will be beneficial in guiding interventions that promote early detection of TB, retention of individuals with TB, and treatment adherence in a sector that is not fully engaged. So this phenomenon of the missing individuals with TB led to the natural question, where are they? And how have other researchers in the past been able to find them, or even tried to find them? While delays have been studied extensively, the practice of mapping the journey of people with TB on a more individual level is very recent. Researchers commonly use graphical tools to describe the care trajectory through predetermined time points. So, few examples. Mystery et al. In 2016 used flowcharts to illustrate provider switching. So, number of individuals and whether they went to the public sector or the private sector. And the phenomenon of bouncing back to the private sector after a referral perhaps to the public sector was able to be visualized. So as you can see here, oh, I'm sorry, the image is blocked by the words, but I'm going to carry on. Atre et al. In 2022, they added an additional scale, illustrating the number of encounters. So as you can see here, these encounters and where they end up, right? In the previous image, we just had diagnosis and treatment. But over here, we were able to see where they got diagnosed and how many visits they had until they were able to get diagnosed. Dr. Bonnie Lestari, who's present with us today, she published a paper and she utilized Sankey charts. So I'm so sorry, it's kind of hard to see. Let me just change this really quickly. I'm so sorry. Here we go. There you go. The Sankey charts. So this is a flow chart that will help us, again, move through the initial presentation, site of TB diagnosis, and site of TB treatment, and it shows us the proportion of patients that transitioned through. And these bits help us realize, so from perhaps a private sector, some went into a more higher level facility as opposed to a lower level facility. And again, Dr. Bonnie Lestari also utilized these stacked bar charts. This showed sequential encounters. So in a public hospital, we had approximately 16 maximum visits that a patient had. This line separates the people who were diagnosed from the people who were not yet diagnosed. So as you can see, by the 16th visit, 100% of the patients in a public hospital were diagnosed in the public hospital. And the colors show, the intensity of the colors show the higher level of practitioner. So going from an informal practitioner to a more formal practitioner, and shows us the difference between diagnosed and not yet diagnosed. So some meaningful findings I did find as well. The results of the methods were promising. Examining the trajectory of an individual with TB that they go through accessing care has major implications for policy and recommendations. So after examining the care-seeking behavior of individuals who were registered under the NTP, some researchers were able to advocate for an increased effort in persistent educational campaigns to raise awareness about where they could even get the treatment and diagnoses. Similarly, in the context of Indonesia, we saw that the findings showed most individuals began their journey at informal, non-public services, such as pharmacies or drugstores or community-based health centers. However, the stacked bar chart showed us that patients did not encounter diagnostics until they transitioned into that higher level provider and having to go through multiple different visits to multiple different providers. So this is why, right? We know where to find the missing individuals with TB could be informed, that could be informed by the care pathway analyses. And finding these individuals obviously makes it easier to care for them. And this is why we're doing what we're doing. So I have this slide for reference, but I think for our purposes, what I want to emphasize is that you must already know what variables are required to recreate some of that research that you previously found, right? So variables of interest are demographic variables, health-related variables, and perhaps their insurance status, perhaps just information about your population. And then my outcomes of interest was most commonly the delays, right? How long did they take to get to where they wanted to go, and dates of their visits to various healthcare providers, dates of when they were diagnosed, when they got their treatment, when they were successfully treated, and where they went to, how many times they went there. All this data was very valuable so that I could recreate those similar graphs. So very quickly, our data collection happened at different times within and between countries. Between May 2021 and February 2023. So you can see that we started our data collection in the bigger COVID project, and we had multiple surveys going out. But for our research, I mostly looked at the care pathways of individuals with tuberculosis before and during the COVID pandemic in Bandung in Indonesia. So this is the manuscript that we ultimately published once we got our data ready, analyzed, and written up. So again, back to our pyramid. We have done the feasibility analysis. Through the literature review, we know our motivation, as well as what graphs and what figures I'd like to create so we can get my findings across. And perhaps I will recreate multiple so that I can choose what goes in a manuscript and what goes in presentations and what goes into the world. So the statistical analysis plan, let's talk a little bit about that. So we'll talk about our descriptive analysis, inferential analysis, and reporting. So the first step is usually just describing our sample. Some common demographic variables include age, sex, and the highest education level that my patients went through. And then we can start describing visually something that is a little bit more interesting and towards our goal. So in this Sankey chart, I show what proportion of population went where for their site of diagnosis, their site of treatment, and I created this chart using R. So you can see the informal providers, where they were patients who had the initial presentation at the informal providers, where they were split into before COVID and during COVID. This stacked bar chart separates the population by those who were diagnosed and again, who weren't diagnosed yet. So as you go along the x-axis, we see that more and more people got diagnosed, but where? Before COVID, it used to be private practitioners, and then it became more private hospitals, sorry. This chart was also created in R. And this matrix shows shows individual pathways before the patient was diagnosed. We can see that overwhelmingly from reds to yellows. So red is the informal provider and yellow is my private sector. And during COVID, we still have a little bit of red that patients started out in informal providers, but we can see that they transitioned mostly into greens, which was my public and community health centers. This chart I created using Excel, Microsoft Excel. So descriptive analysis gets us to one place, and it helps us see what our populations are, but it doesn't tell us why they are the way that they are. And it's up to you to decide as the researcher if this is enough. As another feasibility analysis required now that we have more knowledge of our current evidence. So inferential analysis, now the next step usually involves some sort of regression. So factors associated with. For this study, from the outcome of interest was delays. Were women more delayed than men? Were people with health insurance less delayed than people without health insurance? And is there a third reason confounds or biases my relationship one way or the other? And then finally, we get to reporting. And I suggest following a conventional format for scientific reporting with the following sections. You start with the background, methods, results, discussion, and you start with your abstract, and illustrating and informing without influencing or forcing beliefs. So do not try to influence the reader of your scientific report in any which way. Just try and present your findings and do best by your data. So some best practices in these approaches: for your literature review, decide if you have time to do an extensive systematic literature review or if a targeted is better suited. Each approach has its pros and cons. During your feasibility analysis, try to stay emotionally unattached and unbiased. And be aware that your research question might change. You might find something more interesting to pursue, more fitting for your region or your population, and go with the data rather than take your data and your analysis where you think it should go. So make sure that you understand the risk of the bias and the risk of presenting a predetermined theory. Thank you so much for your time today. I'd like to thank all our participants of this presentation, and Dr. Bonnie, who worked with me very closely as we were writing the manuscript, and Dr. Charity Omenka as well. Thank you so much.
Thank you so much, Lavanya, for showing us how you use the patient journey analysis for your work, and also for highlighting to us why you need to do a literature review first to kind of understand your own context and other research, what other researchers have done before you, so that you can target your study properly. Your results are really very beautiful to see, and it's easy to see, where patients are going, what kind of providers they are accessing along the way. Thank you again. So next is Bonnie. Bonnie is going to talk to us about the impact of COVID on, the patient experience and the patient journey analysis, also from Indonesia data. Thank you, Bonnie. Over to you.
Okay. Okay, thank you very much, Charity, for a very nice introduction. And it's very nice to meet you online again, Lavanya. Okay, so maybe there is some, let me share screen first. Yeah. And maybe there will be some of my slides will be overlapping with Lavanya, but maybe I will be more focused on what we did in Indonesia, because we have the opportunity to do some kind of repeated patient pathway analysis, because we had an opportunity to have a comparison. So we did the first patient pathway analysis in 2017, and then we had the opportunity to again did the same study in 2021, I think, until 2022. So I think it's a good comparison how we can use this patient pathway analysis to guide us about the gaps in patients' behavior, and also guidance for further intervention. So yeah, so my outline today will be some overview about TB burden in Indonesia. Maybe for those, we are currently ranked second worldwide for the number of TB cases, and then the second would be how we can understand the impact of COVID-19 in terms of TB care seeking behavior. We can then I will describe the comparison of pre-COVID and during COVID for like distribution of delays, the pathway, the missed encounters pathway, and then factors associated with delay. And then it will be closed with the key finding, conclusion, and recommendation. So let's see first about the burden. So yeah, so currently, of course, Indonesia is the second largest TB cases in the world, and the COVID pandemic also like set back our progress for TB control. So during COVID-19 pandemic, we have 14% decrease in TB case notifications, and also 47% decrease in TB treatment coverage. Yeah, so as like Christophe and also Lavanya already mentioned, so patient pathway analysis is like a method that we can use to summarize the service delivery by measuring where the patients go, like the patient's journey, and we somehow like cross matching the data with the availability of the diagnosis, TB diagnosis availability. And for the delays, we can combine the pathway also with the delays by taking informations on the dates where patients goes, like we can measure where from the dates of the onset until the first consultation with provider. So we have this patient's delay concept, and then the date when the patients go to the practitioners until the TB diagnosis, where we have providers delays. And once the diagnosis is there, when the patient actually start the treatment, so we call it treatment delay. So we use this kind of framework to also combine the patient's journey, and then we can measure the delay. So this is an overview a bit of where we did the study. So the first study was called In Step 1 in 2017 to 2019. So we mapped the Bandung city and I think it's almost the same, like when Christoph mentioned also in Lima. At the time, they don't have a good quality of data about the healthcare facility, maybe like especially at the private sector. So that is also happened in my city, where we don't have a good data on how many actually private clinics, private providers actually practicing in our city. So the first thing is we do the mapping. So this is the figure from 2017. So this is like the density of the healthcare facility. And then this is something that we do during COVID in 2021 to 2022. We did exactly the same. So we first do the mapping of the providers, and then we did exactly the same thing like what we did in the first study. So this is like having two cross-sectional study, measure how we can like, we do exactly the same thing. So we first do the mapping, and then we select the same puskesmas area, we call it. Puskesmas means the community health center area. And then we randomize, and then we do the data collections. So what's the result? Yeah, so this is a comparison. So this is also from the Lavagna's paper. So we learned that the median, so patients delay between these two studies is, well, it's comparable, but of course during COVID, then it tends to be more delays, like in the COVID, they have 32 days delay compared to the previous one, we have 28 days delay. And then for the provider delay, it's like from the time patients show up at the clinics until the diagnosis, it took 15 days, and it even longer from during COVID. But we don't find any difference for the treatment delay, because it's still showing the same result that with the median of 1 day. But then if we see the care pathway again, so this is the Sankey diagram showing where the patients go. So this is the first bar. And then this is where the patients get diagnosed. And this bar showing where the patients get treated. And then if we compare, then we can see that in terms of where the patients go, there are more patients go to the informal providers during COVID. And then the proportions of patients going to the community health centers is even decreased during COVID. And I think this is understandable because our community health center is public owned. And then at the time, we are also busy handling COVID patients. So less patients come to the public healthcare facility. And then in terms of diagnosis, we can see that more patients go get diagnosed at the private hospital. And then and then in terms of the treatment, so most of these patients get treated at the community health center. And it's even higher during COVID compared to the pre-COVID time. With regard to the misencounter, so this is the stack bar, like Lavagna showed, like where we can try to see where patients miss opportunity for diagnosis or at this area. And this one is the patients that finally get diagnosed. So we can see that the median encounters during COVID is longer, is 7 days. And then more and more proportions, like 75% of these patients actually have encountered more than 10. And then there is some kind of shift of the diagnosis from the private sector into the private hospital. Yeah, and this is, I think, the same, like Lavagna already mentions that also we learned that during COVID, more patients go to seek care at the informal providers, and then the visit before the final diagnosis is actually at the community health center. So one thing that we find different is that during COVID, at that time, we already expand the use of the rapid molecular test with gene experts. So that's why many of these patients get referred to the community health center to be diagnosed with using the gene expert test. And there's also, again, the shift between the notification from the private sector to the public sector in this case. And then if we see again, then in the last two encounters, so with patients over 7 encounters, so 58% were with private practitioners, but then during COVID, it's become less. Yeah, so 44% is visiting the community health center. So I think this is not only just because of COVID, but there's also maybe changing in where the diagnostic tools were placed at that time. So if we assess more what factors associated with the patient's delay, we can see that there is 3 days longer. There's 3 days change in the for patients delay during COVID, and then those who were employed, they face lower delays compared to those who were unemployed. So there's like a socio-demographic factor as well. Because of the COVID, many people have to be laid off and they don't work anymore, and that's also contributing to the patient's delay. And for the provider's delay, so those with more than 6 visits before diagnosis, they have a median of 37 days longer. And of course, this will contribute to higher or longer total delays, but we don't find any factors associated with treatment delays. And then for the factors associated with the number of encounters before diagnosis, now during COVID, people have like 2 more visits before TB diagnosis compared to the pre-COVID time. And for those visited the private hospital as their initial visit, they tend to be quicker to get the TB diagnosis compared to those visiting compared to the community health center. Okay, so some key finding, takeaway message from this study that so individuals, of course, and I think this is almost the same with what Christoph also mentioned, that individual prefer seeking care with private or either formal or informal community level facility, where we also know that the diagnostic capacity is limited. And then the care seeking of individual with TB become more complex during the pandemic. And we see that care seeking becomes longer and more visits, before TB diagnosis were taking place. And with regard to the delays, and the number of encounters is also influenced by the public health and socioeconomic factors, like where do they first go, and also the employment status. And we also observed that there's a notable proportion increase of pre-diagnostic visit to informal providers during pandemic, while the visits to the public sector providers like community health center and public hospital decrease. So maybe this is also due because this public healthcare facility like overburdened with the COVID cases. So then the patients or the community prefers to go to the private sector instead of the public ones. So for the conclusion, so this is, of course, we quite agree that COVID-19 pandemic complicated the TB patient pathway, and there's a need for public health interventions. And as we see, as private sector still like the first gate where patients go to seek care. So I think we need to do better engagement of this private sector in our national TB control. So for example, by ensuring the availability of TB diagnostic tools, maybe something that is easy, rapid TB diagnosis, maybe oral tests, for example, in the first facility where patient seeks care, it will be very helpful. For example, maybe private hospital, private practitioners. And also, as during COVID, there are more people go to the informal providers, maybe we might involve them to refer presumptive TB cases to the TB diagnosis centers. And of course, these all efforts should be also supported by how we can raise awareness among medical and also non-medical communities regarding the needs for quick referral for diagnosis and then prompt treatment. So I think that's yeah, and I would like to thank you as well for those contributing to the study from McGill University, from our research center, from the Georgetown, Benjamin and Jisnu, and then also from our local authority that support our study. So thank you very much for listening. I would like to end my presentation and offer back to you, Charity. Thank you.
Yeah. Thank you, Bonnie. It's really interesting that using the patient journey analysis, you're able to see, the changes during the pandemic. I think one very unique thing about the Indonesia data is that you had, done this before the pandemic, long before the 2 years before the pandemic. And then you were also able to repeat it during the pandemic. And so I think that's one very unique thing about the study that you did, because we are now able to see that during the pandemic, patients were having longer pathways, they're seeing more providers, they were having, more delays, and for various reasons that can be pursued using other research as well. So thank you again to all the panelists. I want to just try to wrap up or try to bring together these two methodologies by quickly sharing my own presentation, and then we'll open the floor for discussions about the practical aspects, like some questions that we can see, like how do we go into, doing all these different analysis on our own. So I'll just share my screen now, and then we can go through what I have and, hopefully tie it all together. Okay, should be this one. Are you all able to see my screen? I hope so. Okay. All right, here we go. So I'm just going to wrap up what we've all talked about by just, sort of talking about the lessons from doing TB patient pathways and journey analysis before and during the pandemic. By way of outline, what are the benefits of doing both methodologies, and, just sort of summarize these methodologies for those of us in the audience that want to do them as well. And then what are some insights? Bonnie has shared that, so I will not dwell too much, but I'll still try to summarize it. So what are some of the reasons why TB patients are lost, right? We said that the main reason why we do patient journey and patient pathway analysis is because we want to find out where our patients are. Where are all of these TB patients? WHO data says between 3 to 4 million patients that have TB every year are not even diagnosed. They are missed by the system. And some of the reasons that the data has shown is that patients are sick, but they are not accessing care. And maybe this is because they don't have very strong symptoms or have no symptoms. They are sick, but they cannot afford care or are self-medicating, or they are seeking care where there are no diagnostic capacities, right? Maybe with informal providers. WHO has also said that some are accessing care, but they are not being diagnosed, right? Because the diagnostic equipment is unavailable. There's low index of suspicion among providers. They're also saying that some are diagnosed, but they are not notified or treated because, the tools are inadequate at the hospital, at the national level, and all reporting is not prioritized by the government. So some of the benefits for us that we have seen, and it's sort of like in summary, is that when we do patient pathways and patient journey analysis, it helps us to reflect and see where the bottlenecks are from the health system part and from the patient part. And so it helps us to customize TB services to meet patient needs more effectively. It really helps us to pinpoint exactly where patients are meeting obstacles. Christoph's study showed that, the the private sector was largely ignored before, but now showing that a lot of patients were turning up at those private sector facilities and then they were not getting care, right? So it helps us to pinpoint where exactly patients are getting missed. And then it helps the government and even the global health community to allocate resources more effectively when you understand how patients are accessing care. It also gives us, insights for developing policies aimed at enhancing TB control. Now, I want to summarize some of the methodologies that, the two methodologies that we've spoken about today. But to do that, I want to just reflect on some of the studies that, or some of the concepts that have helped us, like Lavanya mentioned, and, just to say that there's one, for example, that is the cascade of care. And it's upon this that both methodologies rest on this concept. Like there's a TB cascade of care showing that, there are patients who have TB and they are out there. There are lots of patients. So every year, the WHO estimates about 10 million people globally have TB. How many of these 10 million people ever access testing? That's the first step, right, in the TB cascade. And out of those that access testing, how many of them get diagnosed? That's the second step. And out of those that are diagnosed, how many of them get treated? Out of those that are treated, how many of them are cured? This is the concept of the TB cascade of care, right? And so if you try to, within that whole concept, if you try to understand, where exactly the patients are going, if you want to look at it from the patient's perspective, first you want to say, from the moment that the patient had their symptom, who was the first provider that they went to? And where was the first place that they got tested? Where were they diagnosed? Where were they started on treatment? And did they have a cure or not? Right? Within that whole concept is also the concept that Bonnie touched on, which is the concept of delay, right? What are the different types of delays that patient can encounter when they are seeking care? There's the health seeking delay, right? Which is, the time between when they first had their symptom and when they went to the very first facility. Then there's the provider delay, which is the time between when people were first, like when the individuals first went to their first facility, right? And the time they eventually got diagnosed, even if it is 5 providers later, that's still a provider delay, because, if the first provider knew enough about TB, they would either have tested or had referred the patient correctly. And then there's a treatment delay, which we are finding that is among the smallest delays, because once the patient is tested, it seems like our health systems are very efficient in placing them in care very quickly. And so we have seen from several studies that treatment delays are usually like 1 week. Where our major problem is between the symptom and diagnosis is where the major gap is. So the two methodologies we've seen today is the patient pathways, which is health system focused, really like looking, now you want patients to have access to care. Where are the resources for them to access this care? Where are your testing facilities? For example, in Ontario, Canada, where are the places that patients can test for TB, right? And is it the same place where they can get diagnosed? In any country in the world, where are those places? Like trying to map, where are the resources that will help patients to get access to testing, to help them get diagnosed, to help them get placed for treatment? That's the whole aim of the patient pathway analysis. And then just seeing how well these services align with the demand. Like what is the percentage of patients that are seeking care at each of these points in the cascade? And, so that helps you to see, is there a misalignment between where the resources are for testing and where patients are going, or the numbers or the demand even? It's more like the supply and the demand. Then we have the patient journeys, which is focused on the patient's experience. From the time you started coughing, where did you go? Who was the first provider that you saw? When you saw him, what did he ask you? Were you tested for TB? Were you diagnosed for TB there, or were you referred outside? Or did the provider did not even talk about TB? And then you had to go home maybe with a cough syrup, and then later on you went to another provider. So I'm really like following the patient step by step and asking them, where have you been going to? So this is the first methodology, is the patient pathway analysis that Christoph really demonstrated for us. And like I said, it's just more about, talking about the alignment and showing, the public sector providers, the private providers, the informal sector, how well are they plugged in into the whole TB landscape, and how well are patients accessing the right and appropriate care for themselves within this landscape. And so, it can give you really beautiful charts like this, where you are able to see where the mismatch is. What is really commendable about the study that Christoph and his team has done and his colleagues have done is that they've also added the component of the qualitative codes, like showing exactly within, between the first contact with the healthcare provider and the point where they got diagnosed, what were the reasons patients were given for not being able to get those services? And so they mapped it out very beautifully. Christoph mentioned that it's been published, and I've put the link here for those that are interested. The TBPPM also has on their page all of the resources that we're talking about today, and you can go back and explore them as whenever you want, right? So one tool that has been mentioned in those days when I first came across the patient pathway analysis, what was available then was using Tableau, right? And I'm sure Christoph has also seen that Tableau tool, where you get all of the data, and the data that the patient pathway analysis relies on is population-based surveys, health utilization surveys, or demographic health surveys, right? You need to know, in the whole country or in this location, how many places are doing testing, how many places are doing giving patients results, how many places are placing patients on treatment. And you also need to know how many patients visiting these different facilities arrive with symptoms that are similar to TB, right? So now, very, very thankfully, this tool has been made very easy. And one of our participants rightly mentioned that you can go to Links Bridge and download it, and then you can use it. If you're still, if you still want to do it by yourself, I mean, the Tableau tools are there. If you read the Hansen and Chin paper, they put a link to where you can download the Tableau tool. But I think that using the Links Bridge tool is very simplified. You can just plug in all of the data you have from your DHIS, and then you'll be able to create the charts right there. So that's a very good resource. Now, Lavanya talked about the COVID study. The COVID study was a very large mixed method study that was done in 3 countries, in Nigeria, in India, and in Indonesia. We did different types of study. And patient pathway or patient journey was not the only part of this study, right? We had facility surveys, like Bonnie mentioned. We had standardized patient studies, which were more like to see the quality of care within these facilities. We also did cost of TB analysis, also, which is, Lavanya mentioned that, like, if you want to look at the economic side of things, you can add the cost of TB care to your patient journey analysis to sort of understand what the issues are, what are the barriers that are related to the socioeconomic status of the patient. So we collected a lot of data. That's the summary. Right. In addition to that, we did literature reviews. Lavanya mentioned that we did several literature reviews, and one of them was really like targeted at the methodologies using, focused on understanding health-seeking journeys. Right. Lavanya mentioned very beautifully that several authors have been presenting these studies in different ways, like understanding patient journeys. Right. Authors present their charts or their results in very, very interesting ways. There are some that use flowcharts, some use tables, some use stacked bar charts, like Bonnie and Fuadi and several authors. Some people use different, there are just so many tools out there, different types of charts that people have used that we found from our literature review. So what we came to understand about patient journey from all of that literature review and from our own study is that there are several variables, if you will, or themes that need to be focused, because you can use mixed methods for all of, so let me rephrase. For the patient pathway analysis is really a quantitative analysis, right? Because you're using DHIS and all of that. But Christoph has added a component of qualitative research that is very useful, but you cannot do the whole patient pathway analysis using qualitative data. So qualitative data is sort of complementary to that. For the patient journey analysis, you can actually use qualitative data alone to generate it. or we don't recommend it, but it's possible, right? But you can use qualitative, you can use quantitative, or you can use mixed. In our case, we use mixed methods. But what it helped us to understand is that there are different ways, or there are several key variables that help us to understand the patient's experience when they are seeking care. So from the symptom recognition and the encounter that they go to first, what was that encounter like? We found that if patients go to the public sector, they are in overall, with some exceptions, they are more likely to be diagnosed quicker than if they started with the private sector. And this is because there's a disconnect between the private sector and the public sector in a lot of countries. So they are not talking together. The private sector provider are sometimes overlooked. And then we even have the informal sector, people that are just like maybe the herbal or traditional medicine or the faith healer. Those kind of providers are also there that are completely overlooked. And we find that when patients start from there, then they end up with longer journeys. But in any case, what we found that is helpful to talk about the first encounter. Where was that encounter? Who was the provider that they saw? And then the subsequent encounters that the patient had before they got diagnosed, before they got treated. And if you really want to get deep into it, you want to say, how many encounters did the patient have before they were tested, and before they were diagnosed, before they were treated? Then we said, for each of these encounters, you really need to look at the type of provider. Is it in this, and what qualification the provider had? Is he a medical doctor? Is he a pharmacist? Is he a community health extension worker? What type of provider was that? So this is what we found, right? And then of course, there's the concept of delays. When you look at the timing between each of these encounters, then the concept of delays comes in. Now for the patient journey framework that I just talked about, is just really summarized into delays. The initial health seeking delay, the provider delay, the treatment delay. Then there are the journey elements, number of visits that I mentioned before, testing, diagnosis, and treatment. And between these encounters, what proportion of patients are getting tested, what proportion are getting diagnosed, and what proportion are getting treated, similar to the pathway analysis. And then nested within that is sort of like, okay, no, within that also is the concept of the provider characteristics. What is the qualification and what sector is the provider in? And then of course, you want to see what the risk factors are, or what the factors that are associated with all of these other variables. You want to look at the patient characteristics, their age, their gender, their education, income, and so on and so forth. So we summarize these variables or factors into a table that will soon come out in the paper that we're working on. We're in the final stages in submission, and hopefully the TBPPM will share the link once we submit. But we summarize all of this into the number of encounters, and we define that based on our literature review. Now the resources for patient journey analysis are still very crude, if you will, because it's still ongoing. You can do them with Excel. Lavanya would tell us, or told, she didn't mention, but I'm aware that it took her a long time, sometimes using the Excel and then moving it to R. You can also use Tableau, you can use different tools, but we're hoping that with time, we'll be able to sort of standardize it the way that the patient pathway has been standardized. What are some of the insights that we have gotten, right? Just reminding you, like when we talk about the insights from the COVID study, we're really looking at these key concepts: the delays, the journey elements, the provider characteristics, and the patient characteristics. So in terms of delay, what we found, Bonnie really illustrated that delays changed, because of the pandemic, but generally patients were, having almost 60 days before they started seeking care, right? This was not quite the same in India and Nigeria. The delays for health seeking were less in those countries. And then treatment delays were very low in Indonesia and slightly longer in Nigeria and India. But however, like I said earlier, they're all under 1 week. Then the mean number of encounters in the 5 cities we did within 3 countries, we found that the mean number of encounters was higher in Indonesia compared to the other cities. Right, I'm just going very quickly now, and then using the Sankey chart, like Lavanya mentioned, we used that as well in India and Indonesia, and it helped us to see, the flow. The Sankey chart helps you to see. It illustrates very beautifully the flow between providers. What's the proportion of patients getting diagnosed or treated or or whatever outcome you're looking at that stage, you can see it beautifully when you illustrate it using the Sankey chart. Then the matrix chart, this chart, you've seen it quite a bit within this webinar. Lavanya mentioned it, and and Bonnie also highlighted some of the lessons from this, but this is the matrix chart. It helps you to see the type and sector of provider. It also helps you to see the number of encounters, because if you look very well, each row represents each patient, right? So you can see that some patients had a lot of encounters, and then the columns are sort of highlighting the number of encounters. So each row represents a patient, and then the columns represent the number of encounters. We did similar charts in Nigeria, and we found not as many encounters like we highlighted earlier. The number of encounters were fewer, and so the chart is not as deeply as it's not as complex as the one we have from Indonesia. We also did it in India, and you can see, but within this type of chart, which is like the matrix chart or the stacked bar chart, you can see the type and sector of provider. You can also see the number of visits. So generally, in conclusion, because Indonesia has been mentioned by Bonnie, I won't dwell so much on that, but in Nigeria and India, we found that before the pandemic, looking at this, the literature before us, people that have done these studies before us, and during the pandemic, while there were some changes due to the pandemic, they were not as stark as we thought they would be. And maybe this is due to the fact that, our study was done, maybe at the ebb of the pandemic, in 2021, not during the initial panic period. So patients were getting more used to the pandemic, and they were able to access care. So generally, what did we learn, or what are some lessons to keep in mind when you're doing the patient journey analysis? When you're collecting the data, consider your timing and the context, particularly if you're doing in more than one site. Be sure that the rain is not like winter season and you collected data somewhere in Ontario, and then in the spring you went to collect data in Quebec, for example. The results will not be well matched. So you be sure of your context and the timing. And then the timing of visits or encounters. Really, what we have found to be very helpful from the COVID study is that you need to express that in dates, right? If you just say, oh, tell me days, and the patient estimates for you, if you want to go back and do some of the fancy stats, it will be very difficult. So you really need to work with the patient to sort of jog their memories however you can, either by looking at their phones or their pictures or events that happen in the country or whatever, to try to like nail down a date. Do you think it was the beginning of February? Would you say it was the first week, second week, or whatever? Try to nail it down and give an approximate date to when the patient had, first variable that is very important, when your symptoms started, right? So try to give a date to that. Then the date when they had their first encounter, try to write it down. If you think it was 2 months later, you can add 60 days and then say if it was like 12th February, you can now say 12th April or something like that. Just putting those approximate dates were very, very helpful. Because when we collect data without that, then it becomes really difficult to express or to create the charts that we're talking about. Then also trying to talk about the time that elapsed between each of the different steps in the cascade of care, from the symptoms to the testing to the diagnosis to the treatment, right? Just really like saying what was the time that elapsed for the health seeking delay between your symptoms and your first encounter. What was the time that elapsed between your first encounter and the next one, and then the next one, and the next one, and so on and so forth, right? So several ways to overcome and mitigate the recall biases: to pilot your interview tools, train your data collection team, and so on and so forth. So in rounding up, I want to thank all the teams that participated in the COVID study: McGill University and International TB Center, Georgetown University, University of Waterloo, Universitas Pajajaran, Shops Plus, and all the national and state teams that worked with us. Thank you. And so now we could take questions, and then we can wrap up the webinar. Okay, I see a question here asking we should clarify what the informal health providers are, and includes, like, someone has answered: traditional healers, self-made concoctions, It includes faith healers. It includes people that are not trained by the orthodox medical healthcare, right? Like you're not a nurse, you're not a lab scientist, you're not a doctor, you're not a pharmacist. Those are the informal providers. Any other question? Okay, Petra, I would like to hand over to you as we round up. If there are any questions, we're also, listening keenly to answer them.
Yes, there are some questions in the Q&A, and I actually think there's some really interesting points that have been already been answered by Bonnie. Thank you so much. The one question that I see is to all the researchers, and I would love to hear that. Actually, I'm also curious. How did the researchers discuss their findings with policymakers? And what practical recommendations for the national TB program did they put forward? Or did you get a chance to discuss with policymakers? Maybe we can do a quick round to I would love to hear from Christoph and Bonnie and Lavanya as well, but especially Christoph and Bonnie, since you're both based in or have been really actively doing the work. So Christoph, do you want to take that first question?
Yeah. So we, as I said, our results just got published last week, so they're very fresh. And I think I know my mentor Courtney Yuan is very active in Peru, so she will definitely take that forward. And also Sosis and Salud, I think will draw benefit from the results of our studying going forward as they work with policymakers in the national TB program. So yeah, I think there's definitely a lot to come. Yeah.
Bonnie, go ahead.
Yeah, okay. So I think I'm grateful because for this project I work closely with the local stakeholder, the city health office. So at the end of our study, we do like a disseminations of our result, and then we are kind of agreed that we need to do something to better engage the private sector, especially the informal providers. And just recently this year, we got a funding from the WHO TDR to do a pilot project to engage pharmacists. So we will train them how to identify the symptoms of TB patients. We will provide like a checklist tools, and then engage the pharmacy with the local community health center that they have facility for TB diagnosis. So we are piloting that, Petra, as a follow-up, and also with the full support from our local health office for this project. So I think it's good that actually the result from our studies actually can come up with another interventions that can improve TB control. Yeah.
Yeah, fantastic. And I also see Courtney's putting in the chat that the discussions with the national TB program specifically looked at the accreditation from the government for private diagnostic facilities. So that's really exciting to hear for Peru, and definitely looking forward to hearing how that is going to progress. Lavanya and Charity, I know you both have also engaged in discussions with Nigeria and with many of the policymakers in India and Indonesia. Would you like to comment on that maybe? And weave in, if you can weave in the last few minutes, I would like everyone to kind of give a final little comment. I see there's lots of comments on some of the analysis and tools, and thanks Yuri for providing some of the links from KNCV into the chat and into the Q&A. It's really exciting to see that there's many of these methodologies now coming forward, and I think it's great that this webinar is bringing some of the other work to light, and fantastic to have you all here together. There's clear interest also in the informal providers, and that's definitely a topic that we're highlighting much more. There will be also a webinar on that in August, so there is more information coming out on that point of view. The informal providers are really an important area, so that we will highlight that more. But if each of you, and I'm starting maybe with kind of highlight a closing statement for our participants. And Lavanya and Charity, if you want to add on a little bit more on some of the discussions you've had with policymakers, that would be great. But so let me start with Lavanya. Is there anything that you want to add?
Personally, I have not been too involved in after publishing the paper. I think I kind of took a step back from my graduate studies. But yeah, so I'll let Charity Charity take that away.
Thank you, Petra. So yes, like Bonnie mentioned, in Indonesia, it was really very engaged, and the policymakers were there, and we shared the results quite early, and they, went very purposefully to incorporate some of the results in what they were doing. In India as well, our results were presented to, within a meeting of the top, TB program leaders, and I think they are taking forward some of the recommendations as well. Similar for Nigeria, we had webinars, and in fact, the national TB staff were part of, like, knowledge dissemination, I'll say, and just like they've taken our results and they have been working very hard to sort of incorporate some of those recommendations. And to be honest, it didn't come as a surprise to most of the policymakers that we interacted with for the COVID study, which was in Indonesia, in India, and in Nigeria. They were already aware that the private sector was largely, not well integrated with the public sector, and they were already taking steps. And I think that all three countries are working really hard to make sure that they integrate the private sector care into the whole TB landscape to ensure that patients are not missed anywhere. Because one thing that we probably have not talked about is the fact that in all three countries, a large chunk of patients start their care in the private sector, right? 75 to even 85 or even 90%, they start their care in the private sector or even with informal providers. So when the public sector does not engage with these providers, then that's a large chunk of patients that are just missed, right out of the gate. So this is something that is ongoing, and all the countries are doing really well to make sure that these lessons are not overlooked. Yeah.
Great, thank you. So rapid fire, one last question to each of you. Christoph, Bonnie, Lavanya, what is one of the biggest challenges you have had in doing this research, and what is one of the biggest takeaways that you want to say, this is why it's worth doing patient pathway analysis? Christoph, do you want to start?
Yeah, I think the biggest challenge for us was like just going out in the field and actually finding those private providers, because we had some lists from the Ministry of Health that were giving us some clues, but then those were not regularly updated. So we just had to go out in the field and cover the whole area and see where those facilities are actually located in reality. And I think one thing that it showed me, or one experience, is like Charity said, it's really a gap analysis, and you're looking at where are the gaps in the healthcare provision. For example, you can design a TB program and think that nobody falls through the cracks, like in Peru, where in theory everybody is covered for free, but then the reality on the ground is that people do seek care in the private sector, and that the patient pathway analysis can reveal that, and you cannot ignore these entry points for care seeking.
Great point. Lavanya, any last, like, one big challenge you encountered, or one big takeaway that you feel from the patient analysis, patient journey work that you did?
Yeah, absolutely. So as Charity actually already mentioned, the data was the hardest part for me as the statistician, kind of trying to make it more uniform across the time points that I was working with, uniform across the geographical regions. So it may not be ideal, but having the same survey that you set out, and you collect the data in a very similar way. Obviously, you have to make changes in the region that you are, but at the end of the day, if you already have a goal that I want to create an analysis that can show side by side different time points as well as different regions, it would be helpful to have data that also looks similar. So that is one key takeaway, that kind of already know what kind of analysis you want to do side by side, and also definitely having a strong literature review, having a strong basis of knowledge so that you know that there are multiple avenues that you could go down. Thank you.
Perfect. Excellent, excellent. And Bonnie, last word to you.
So I think what I experienced the biggest challenges. So first, in Bandung, we experienced high turnover of these private practitioners. So when I did my study in 2017, maybe like 1/3, when I did again the mapping of these private providers in 2021. So it's like maybe 40% are no longer available. So we need to do a remapping, just like Christoph also, it's very difficult to find the original list of these private practitioners. And once we get in contact with them, it's quite difficult as well to get permissions to interview their TB patients. So they are quite afraid to be engaged with us because sometimes they have different TB diagnostic algorithm than what is suggested by the national TB guidelines. Yeah, I think those two. Over to you,
Yes,
Petra.
fantastic. Those are, yes, I can see that those are general points. Charity, do you want to say one last thing, and then I'm going to wrap up?
Oh yeah, if I would say one thing is that both methods are complementary, and I would say that both are useful. So both are needed in any context where TB is high, to kind of understand, what the health system issues are and what the patient issues are. Only with that picture would you be able to say, oh, this is the reason why our patients are missing. And then you can develop policies that really target those bottlenecks for within the health system and along the patient's journeys, experiences. That would be my last comment.
Excellent conclusion. So thank you all for incredibly insightful presentations and bringing a lot of these beautiful findings to the fore. I think this is very informative for where the TB programs are in these days, to really base it on evidence, which you have shown is possible to bring those findings to the fore. Really appreciate you also talking about the methodology. Thank you to all our participants for many good questions and for sticking with us. I will say goodbye to everyone. We will be back and we will be posting background reports and everything from this webinar online, and more is coming on informal providers and many other topics that you're interested in. So please stay in touch. Thank you so much. Have a wonderful rest of the day, rest of the evening, and really appreciate everyone. Goodbye. Thank you. Thank you.
Bye, everyone. Thank you.
Bye, everyone.